टू बिगिन विद एक छोटा सा फॉर्मल इंट्रोडक्शन। डॉक्टर
Okay.
कांत जोगानी हमारे लीडिंग न्यूरो सर्जन हैं और डॉक्टर साहब वोकार्ड हॉस्पिटल्स में अपनी सेवाएं देते हैं। एंड वी वेलकम यू डॉक्टर कांत जोगानी सर, एंड वी ट्रूली अप्रिशिएट एंड रिस्पेक्ट दैट सर आपने स्ट्रोक सपोर्ट इंडिया, एक पेशेंट सपोर्ट ग्रुप फॉर स्ट्रोक के लिए अपना कीमती समय निकाला। वेलकम यू सर।
Yeah. Thank you for giving
एंड
me.
हरदीप सोधी सर स्ट्रोक सपोर्ट इंडिया के डायरेक्टर, फाउंडर, प्रेसिडेंट, and I don't have words, sincerely Sodhi sir, I don't have words to describe the dedication and devotion with which Stroke Support India is working for the betterment of stroke affected families. We again welcome you, Hardeep Sodhi sir.
I will just again emphasize the importance actually of stroke awareness a little bit. As you know, Khan Saab bhi bolenge, time is of critical importance when stroke happens.
Right.
Within a few hours, right treatment should be started. जो कि golden hour 3.5 की बातें करी जाती हैं. So that is a major portion, and of course we are going to talk about various other measures after the stroke has occurred. और आज हमारा फोकस कान साहब आपके साथ ऑन रहेगा ऑन थ्रोम्बेक्टोमी एंड एम्बोलेक्टोमी, जो कि हम बात भी करते हैं एंड उसमें हमारे ग्रुप में भी कंफ्यूजन रहता है कई बारी. तो अगर इफ यू कैन इलैबोरेट अपॉन दीज टू प्रोसीजर्स सर, क्या ये सेम है, क्या ये फर्क है, कब क्या होना चाहिए, इफ यू कैन टॉक अ लिटिल बिट, थोड़ा सा आप बताएंगे.
ठीक है. सभी आप जानते हो कि स्ट्रोक इज अ वेरी कॉमन इन आवर कंट्री, इज द थर्ड लीडिंग कॉज ऑफ death in our country as well as in the world, is a leading cause of disability due to the severe stroke, and we try to reduce the disability and mortality in our society, because disability and morbidity is a very huge burden in our society and in our country also. Incidence is about 150 to 200 per lakh per year population. As far as the concern with the thrombectomy procedure, when should do and when should not do. Usually 50% of the stroke can be prevented, and only 15% of the patients reach to the tertiary care center within 6 hours, and only 1% of the stroke patients is fulfilled criteria for mechanical thrombectomy. As you know, what is the thrombus and what is the embolism? There is a two difference. Thrombus is whatever is the blood clot or atheromatous plaque. It is stuck within the vessel. It is called as thrombus. Once it is traveled through the blood vessel, it is called embolism. So that is almost similar, thrombus and embolism. The moving part is known as embolism. The thrombectomy is a removal of thrombus, and embolectomy is the removal of embolism. Both procedures are same. There is no much difference. Procedure are same, and indication are almost same, because and thrombectomy, there are two types of thrombectomy. One is open, and second is balloon endovascular. And we are doing an endovascular thrombectomy. Most of the time we do thrombectomy from the femoral artery. Wire goes into the vessel, into the intracranial. We do usually 4 vessel angiography first, and then where is the site of the blockage, because where the blockage is very important. We do usually thrombectomy for large and medium sized vessels like ICA, middle cerebral artery, anterior cerebral artery, basilar artery, vertebral artery. We cannot do in a small caliber and parenchymal calibers and capillary artery, right? And once the patient comes in our hospital, we take the history very brief, be fast. We take the history, immediately clinical history, and do the CT scan. We have a CT scan in our emergency department. If the CT scan is normal, we usually start IVTPA. IVTPA start, and urgent explain for the procedure what is the thrombectomy, what is the mechanical thrombectomy, embolectomy to the relatives and patients also. And within a couple of minutes to hours, we usually patient penetrate into the cath lab, and we usually do a thrombectomy because the time is very, very important. As you say, golden hour treatment is a gold standard treatment in stroke, because once it is a brain cell death is a permanent, because the neurons is the only structure in our body which is not going to regenerate. So whatever is the damage is damaged permanently, and it gives a morbidity. So our try to minimize the damage to the brain. That's why it is a very important and very fast procedure in our case of stroke. Yes.
ठीक डॉक्टर साहब, जस्ट मेरी क्लैरिटी के लिए, जैसे मैं समझा, जैसे आप बोल रहे हैं, थ्रोम्बेक्टोमी तब है जब प्लाक है आर्टरी के अंदर, डिसलॉज नहीं हुआ है। अगर वो डिसलॉज करके अपर और ऊपर चला गया है या क्लॉट बन गया है,
दैट इज नॉट,
वो एम्ब्लोक्टोमी है। मैं समझ गया। तो एंड जनरली यस, प्रोसीजरली दोनों का तकरीबन सेम रहेगा। मैंने समझा जब पेशेंट आता है, फर्स्ट अटेम्प्ट तो होता है कि जैसे आप कह रहे हैं सीटी स्कैन करके कि
सीटी स्कैन करेगा, we have to rule out whether it is a hemorrhagic stroke or infected stroke, right?
Yes. Yeah.
And then we start the TPA and all, thrombectomy and all.
Correct. So if it is hemorrhagic stroke, sir, then of course thrombectomy is ruled out, isn't it?
Ruled out is a contraindication.
Correct. That's a contradiction. So only for ischemic stroke,
treatment is totally changed, and in hemorrhagic stroke, we have to evaluate how much is the hemorrhage, where is the hemorrhage, and it is causing the mass effect or not. If it is causing the mass effect, immediately patient should control the BP and take him to the OT. We remove the clot as well as reduce the intracranial pressure. That is the main.
Right. That the pressure. So, if the patient is having an ischemic stroke and the CT scan reveals possible thrombectomy or is possible, then I understand पहले तो आप attempt करते हैं using the intravenous, the TPA.
Intravenous TPA.
While you are administering it, you are also maybe preparing yourself as well as the patient's relatives that could proceed to a thrombectomy or a thrombectomy procedure. क्योंकि the TPA may not be very successful.
May not be very successful.
The clot. So normally, sir, let us say
in the case of when you give a TPA alone, the recannulation is only less than 30%.
Okay.
If you give the TPA, IV TPA and thrombectomy in a large, smaller, medium-sized vessel, recannulation is chances to 50 to 80%.
Okay. So once you have given, let's say, TPA has started, how much time normally would you wait before you start or decide that no, it's time for proceeding to a thrombectomy or an embolectomy procedure?
Usually, if the patient is okay, then we go for a MRI fast. That is known as diffusion study and ADC stay. If the penumbra is there, then we start the embolectomy. If there is a large vessel and medial-sized vessel, usually we post it immediately for thrombectomy.
Okay, so if it is generally speaking a larger vessel, you would probably move towards a thrombectomy procedure. And as you say, it is as of normally it is a non-invasive procedure. It's a femoral artery se aap you proceed, and usme as I understand, there are mechanical retrievers now जो जाके उस clot को pull करके बाहर निकालते हैं.
Because we have to try to minimize the minimum damage to the neurons.
But in case, let's say it's an embolectomy and the clot has traveled further upstream to the final
right.
Then is thrombectomy still indicated, or then?
No, not in this. Not indicated. If it goes inside the small caliber artery, then thrombectomy is not possible. It's a M2, M3 segment is not possible. Then we give IV TPA.
Then it is IV TPA is the sole means of operating or working on them. I understand, sir. I understand. So, as I understand, both are generally speaking the same procedure.
Same procedure is the same procedure. The
But do you I mean, in your records or in your operational records, do you specify as it was a thrombectomy or it was an ambuloctomy? I mean, say the two are separate.
Most of the terms accepted is a mechanical thrombectomy.
Okay. Okay. So most of the time it will be mechanical thrombectomy will be the process. And I would imagine a cath lab mein hota hai, and of course there are screens to assist jiske through wo travel kiya jata hai, and it needs a lot of skills.
Sometimes we see a large clot in a catheter. Once remove the clot, the size almost 2 to 3 centimeter long, and usually in distal ICA or proximal MCA arteries, and we can see the clot in a device. Yeah.
Correct.
Yeah.
And these procedures are mechanical thrombectomy.
Yeah.
How old it is now? Is it a well-established procedure?
It's a well-established art for a couple of years. Before 2 decades, there was no thrombectomy, no cath lab everywhere available. And the thrombectomy comes last 5 to 6 years more commonly we use. Last 3-4 years we are doing regularly. We are doing setup usually 3-4 thrombectomy per day.
Oh, I see. Okay.
We have large
Is it also connected, sir, to carotid artery stenting? Does that proceed simultaneously, or is it a different procedure?
It's a different procedure, because we have to use the filter and all that things in a catheter in a.
So, abhi hota hai? What is the preferred treatment nowadays? Is it still stenting, or one tries to go to thrombectomy?
What?
Between carotid artery stenting and mechanical thrombectomy.
Yeah.
Right now, which is the more, let's say, preferred or the safer option?
Carotid stenting is relatively a elective procedure. In many patients usually moving around and thrombectomy is the emergency.
Okay.
They can't give it time. Thrombectomy is a very emergency, and carotid stenting is a planned procedure. In many of the cases. Yeah.
Okay. When you have time and the patient can be prepared and investigated properly, then you can proceed to carotid artery stenting.
Usually when there is a TIA, transient ischemic headache, when the Doppler suggests if there is a 60 to 70% blockage with symptomatic site, then usually we do a carotid stenting or endarterectomy. Both we are doing. Stenting as well as the carotid endarterectomy.
I understand, Doctor. And moving on, what are the precautions post thrombectomy agar hum baat kare, which the patient should keep in mind, for maybe safe recovery, better recovery after?
Right. Immediate जो होता है, जो immediate जो precaution लेना पड़ता है, वो patient को ज्यादा से डॉक्टर को लेना पड़ता है. जो regular जो अगर patient को लेना है, तो post procedure later they have to take regular medicine, because the most of the patient is on anticoagulant drug, and most of the time is a single or dual, either aspirin, clopidogrel, or both. Then they have to control the diabetes, hypertension, hyperlipidemia. If the cholesterol level or lipid profile is very high, then they have to control the lipid, or stop the smoking, alcohol. If the patient is a female patient and taking contraceptive pills, then they have to stop it. Then obesity, in case they have to reduce the weight and regular exercise. Immediate complication in the case of thrombectomy is reperfusion injury, very, very common. Sometimes the larger area of the brain is involved. And if you do a thrombectomy, mechanical thrombectomy, there are chances to reperfusion injury. There is a hemorrhage and leakage the brain, blood inside the brain. Then we have to take care for that. And the contrast allergy, some patients have a contrast allergy. Then we have to take precaution for contrast. If the longer procedure, more contrast use, we have to check with the urine serum creatinine and the kidney function. Then excess site we have to monitor. The patient should tell him and ask him then the leg is not going to move, because most of the time we do a femoral catheterization. If a femoral artery is punctured, we usually apply tight bandage, tight dressing over there, and immobilize it for 6 to 7 hours, so that there is chances of hematoma is very less. And second complication at the site is infection and pseudoaneurysm. What happened once you prick the femoral artery, then chances of pseudoaneurysm is relatively uncommon, but it is going to happen. And third thing is the vasospasm. Sometimes you do a mechanical thrombectomy, the vessel intimal injury is little more. So chances of vasospasm is little higher. Sometimes as a vessel is going to perforate with the catheter. Then we have to take care and identify there is a vessel perforation is dye, contrast is leakage outside or not. And then other is dissection, arterial dissection and residual stenosis. Residual stenosis, sometimes what happens, once we do a thrombectomy, the vessel is going to open. And after 2 to 3 minutes, the vessel is going to block again. Then we have to take care, right? Yeah. Okay. And rest of the BP control, sugar control, temperature control, all we have to take care. If the patient is having a fever, give a corresponding hyperpyrexia treatment. If sugar level is little higher, then we have to control the sugar level, and blood glucose is common. If it's the diabetic patient, you have to take care for the diabetes also.
Dr. Saab, this is a local anesthesia procedure or is it general anesthesia?
Most of the time you do a local anesthesia, but patient is, if the uncooperative patient, if the left-sided stroke, patient can't understand. If left-sided stroke, understanding is poor,
Correct.
Patient is not going to follow whatever you say. In that cases, or basilar artery thrombosis is very common, because basilar artery thrombosis, patient usually comatose patient. In comatose patient, we usually intubate it first, then we proceed for the thrombectomy. The thrombectomy, local anesthesia, when there is a patient is very cooperative, patient is not moving head and understanding. And sometimes we give local anesthesia plus some sedation. In patient is totally unconscious, we give intubation, full anesthesia, and they do a thrombectomy.
And you talked about contrast allergy. What I understand,
contrast
जो उसमें आप देखते हैं जो डाला जाता है maybe the chemical so that the so one has to monitor.
Nephrotoxic basically is a nephrotoxic. If the procedure is longer time and you need a contrast large amount, then we have to monitor the urine output, serum creatine level, and all.
Okay.
Sometimes is having a borderline severe. Most of the time, what patient having a blood pressure, hypertensive patient, diabetic patient, so his serum creatine level is little above the borderline, 1.5 to 2. In that cases, we have to take care, no more contrast use, minimum contrast using in that cases.
So this all this monitoring of creatine levels is going on in the operation theater itself.
No, not in the operation theater. After operation theater.
After operation, after the patient has come out of the operation theater.
What do we do is we do immediately all the preoperative profile, preoperative. And then in that cases we have to check the contrast serum creatine level.
Okay.
What was the creatine level before the procedure? And we have to monitor whether it is increasing. Then we have to take it.
Then you have to take account of this.
Nephrotoxic.
And this procedure, it is normally for how many hours? Or uske baad hospital stay?
Most of the time, 1 hour to 1.5 hours. Most of the time, because the larger clot, cath lab preparation, and all that things, and is very, and check after 5 to 10 minutes again to check the dye with if the vessel is not going to block or not. That.
And uske baad hospital stay kitna under, let's say most cases kitna?
Depend on the patient, clinical, how is the patient came with the comatose, then there is admission is very longer time. If the basilar stroke, most of the time in a basilar stroke, patient usually keep in hospital for 8 to 10 days. How is his condition, clinical condition? But smaller vessel, left-sided stroke, and patient is okay, then 4 to 5 days we monitor and then discharge.
Along with, of course, jo aap keh rahe hain, precautions to the patient that they
Sometimes
need to be.
if the larger area of the brain involved and recannulation, after the recannulation, there is an infarct, then in that patient, we have to monitor the area is not going to much more involve edematous. Then sometimes we need decompressive craniectomy, hemispheric craniectomy, if the larger area and patient is deteriorating. In that cases, need longer time hospitalization.
But normally, iske baad, just as an aside, Dr. Saab, what are the possibility of, let's say, recurrent stroke? ये procedure भी हो गया, patient इलाज हो गया, वो घर चला गया. Is there a probability that, let's say, within 1 month, 15 days, he can again have the same situation?
No, same situation. Patient usually we started anticoagulant drugs. Most probably we started dual antiplatelet agent. So chances of readmission and stroke is almost 5 to 10%, 5%.
Okay. And what about, जैसे, should the patient be concerned? जैसे हम तो as a layman सोचते हैं कि जब मैं गिर गया after operation के बाद, फिर मैं गिर गया, let's say.
Yeah.
उससे क्या दोबारा ब्रेन के अंदर कुछ कॉम्प्लिकेशन हो जाएगी, कुछ?
Yes, we have to tell to the patient, they have to take care, so they don't drive for 2 months or couple of months, because there are chances of vertigo and all. Patient usually most of the is a dual antiplatelet agent. The trauma is dangerous for him, right? So they have to take care for everything. They have to control the sugar level, regular stop the smoking and alcohol and all predisposing factors. That if they take care, and then the chances of re-stroke is very less. Medicine is very, very important. Hyperlipidemia usually start atorvastatin.
और दूसरा, डॉक्टर साहब, ये कई बार होता है कि there is a natural fear कि ऑपरेशन हो रहा है. So as of now, what is the state of art? Does one need to be fearful of a procedure thrombectomy, or is it a fairly safe procedure if the proper evaluation वगैरह हो गई है? And complications की possibilities क्या हैं? If you can, elaborate a bit upon that.
We have to, if the patient is conscious, we have to explain them for patients properly. And if the patient is unconscious, patient is disoriented, the patient is not understanding, then we have to explain to the relative also. What are the advantages of thrombectomy and what are the disadvantages of thrombectomy? करने से क्या फायदा है, नहीं करने से क्या फायदा है, पेशेंट को समझाना जरूरी है कि दिस इज ए लाइफ टाइम प्रोसीजर. एक बार ब्रेन का नुकसान हो गया, मतलब ब्रेन डैमेज हो गया, 3 घंटे के बाद के कल आप बोलोगे थ्रोम्बेक्टोमी कर दो तो नहीं चलेगा, because it is not going to help. Thrombectomy usually we do within 6 hours after the onset of first symptom. दूसरे दिन हम थ्रोम्बेक्टोमी नहीं करेंगे तो उसको बोलना पड़ेगा, अगर आप कल बोलोगे कि थ्रोम्बेक्टोमी करना है तो it is less possibility chance, because once it is damaged is a permanent loss. आपको आपका ए पैरालिसिस परमानेंट रखना है कि थ्रोम्बेक्टोमी करना है. The procedure is very, very easy. There is minor complication, and complication occurs if the treatment is available. So most of the time patient usually convenient, right? The better hai to do. It is not harmful. It is a minor procedure. We are not cutting the brain and all. It is a simple catheter procedure. Without incision is a minimal invasive procedure, and most of the time patient usually convenient.
Because obviously the consequences of not undergoing the procedure at the time,
right,
much more serious, lifelong disability, even much more serious conditions.
Right.
Yes, जो options available हैं, timely options available हैं,
right,
and of course they should be used. Is जो आप कह रहे हैं, and I agree with that. तो ये जरूरी है, और ये I think हमें कन्वे करना भी जरूरी है, जैसे हम
कन्वे करना जरूरी है कि क्योंकि देखो मैं 20 साल से यहाँ न्यूरोसर्जन, 20 साल पहले थ्रोम्बेक्टोमी नहीं होता था, तो मोस्ट ऑफ द टाइम तब IVTPA भी नहीं था. मोस्ट ऑफ द टाइम यूजुअली गिव हेपेरिन, स्मॉल अमाउंट हेपेरिन, and तीसरे दिन most of the patient, infected patient, need surgery, hemispheric craniectomy. Nowadays hemispheric indication is very less, because the thrombectomy comes in the picture. So the larger hemispheric craniectomy is little decrease because of thrombectomy. Most of the time थ्रोम्बेक्टोमी करके वो उसका ब्रेन जो है वो डैमेज कम होता है, तो क्रेनियक्टोमी करने की जरूरत नहीं पड़ती. And chances of morbidity is little lesser, you know.
Correct.
Yeah.
Naturally, I understand.
Yeah.
Now,
तो क्या होता है, क्रेनियक्टोमी करके पेशेंट मोस्ट ऑफ द टाइम हेमीप्लेजिक पेशेंट बेड रिटर्न रहता है. अभी आपको बेड रिटर्न रहना है कि आपको इंडिपेंडेंट होना है, तो ऑब्वियसली पेशेंट बोले कि इंडिपेंडेंट होना है, तो थ्रोम्बेक्टोमी इज द बेस्ट अवेलेबल प्रोसेस इन नाउ.
ठीक. थैंक यू डॉक्टर साहब, आपने काफी अच्छे से एक्सप्लेन किया जो हमारे मेजर कंसर्न्स रहते हैं.
राइट.
हमारे ग्रुप्स को भी, दूसरों को भी ये जब हम देखेंगे, वो एक्सप्लेन करेंगे.
राइट.
सो थैंक यू वेरी मच.
Doing 3 years ago, 4 years ago, hardly we do one thrombectomy per month, one thrombectomy per 15 days. Now we are doing 2 to 3 thrombectomy per day. Yeah. Because we have a large area of drainage, you know. So and most of the time they are away. सबको पता चल जाएगा is a fast, you know. The meaning of fast. तो तब तक तुरंत पेशेंट को पता चल जाता है, तुरंत आ जाता है. Still there is only 15% of the stroke come to the hospital within 6 hours.
हाँ बिल्कुल, ये तो है जो आपने एक्सप्लेन भी किया. आई थिंक वो टाइम्स ऑफ इंडिया का भी एक आर्टिकल था आज से करीब 1-2 साल पहले, सर्वे हुआ था. लेस देन 1% रीच टाइमली ट्रीटमेंट टाइम. मैंने भी देखा था. सो यस, देयर इज अ गैप एंड उसको
बिकॉज़
जरूरत है.
जैसे हार्ट अटैक का पेशेंट जल्दी हॉस्पिटल टर्शियरी केयर पहुंच जाता है, ऐसा इसमें नहीं है, क्योंकि अवेयरनेस इज, यू नो, क्योंकि
सिम्टम्स आर कंफ्यूज.
और थोड़ा टिंगलिंग हुआ, देखते हैं क्या हुआ, थोड़ी देर रुको, तो उसमें टाइम निकल जाता है. उसके बाद ट्रीटमेंट का टाइम निकल जाता है, कब कुछ नहीं कर पाएंगे ना.
दैट इज व्हाई इट इज इंपॉर्टेंट to raise awareness of it. So thank you very much, Dr. Saab, again for your time. We appreciate that, and thank you very much again. Chirag, over to you.
Thank you, Dr. Kant, and lots of respect to Mr. Hardeep Sodhi कि आपने stroke affected families and stroke affected patients के लिए अपना टाइम निकाला. One last thing, Dr. Kant, आपसे ये जानना चाहते थे कि हम ज्यादा से ज्यादा stroke affected परिवारों तक हरदीप सोधी की ये पहल कैसे पहुंचा पाए. हरदीप सोधी सर ये जो पेशेंट सपोर्ट ग्रुप चला रहे हैं, हम ज्यादा से ज्यादा स्ट्रोक अफेक्टेड को ये व्हाट्सएप लिंक और टेलीग्राम लिंक कैसे पहुंचाए ताकि पैन इंडिया में इसकी अवेयरनेस हो ये ग्रुप की. आपकी राय जानना चाहते हैं कांत साहब.
एंड दे शुड नो, पेशेंट, एवरीवन नोज व्हाट इज द स्ट्रोक, what are the chances of for the what is the importance of golden hour treatment, वो सबको जानना जरूरी है, क्योंकि उसमें गोल्डन आवर के टाइम अगर निकाल देता है उसके बाद उसको जिंदगी भर पछताना पड़ता है कि क्या करेंगे हम, वो टाइम पे नहीं पहुंच पाए, बिकॉज द मोर्बिडिटी इन आवर कंट्री इज वेरी वेरी, यू नो. आप एक जानो कि अगर सब एक मोर्बिड पेशेंट, हेमीप्लेजिक पेशेंट घर पे पड़ा है तो पूरा फैमिली डिस्ट्रॉय हो जाता है, पूरी उसकी ट्रीटमेंट में, उसका वो सब में, तो पूरा फैमिली डिस्ट्रॉय हो जाता है.
कांत साहब, ये स्ट्रोक सपोर्ट इंडिया को ज्यादा पेशेंट के तक हम कैसे ले जाए सर? स्ट्रोक सपोर्ट इंडिया की
मीडिया थ्रू ही ले जा पाएंगे. अब नाउ मीडिया इज व्हाट्सएप एंड एवरीथिंग इज अवेलेबल, यू नो, एंड रेगुलर कॉन्फ्रेंसेस करते रहने का है, और रेगुलर वो सब एनजीओ जो चलाते हैं उसको एक्टिव करना पड़ता है कि ऐसा थोड़ा कम्युनिकेशन करे और थोड़ा पब्लिक अवेयरनेस लाए, यू नो.
So sir, if I can just come in, I don't know, आपके maybe आप ख्याल में रख सकते हैं, आपके भी जैसे कोई अवेयरनेस प्रोग्राम्स होते हैं
यहाँ पे, अवेयरनेस प्रोग्राम
we can हम भी
तो यहाँ पे रोड ट्रैफिक का एक्सीडेंट का जो हम यहाँ पे रेगुलर करते हैं, हम और कमिश्नर जो राजकोट के कमिश्नर होते हैं, हम रेगुलर कॉन्फ्रेंसेस करते हैं कि एक्सीडेंट से क्या होता है. मैं उसको काफी वो बताता हूँ, एक सिटी स्कैन, वो उसका कैसे गिर गया था, क्या हुआ था, वो एक्सीडेंट की वजह से क्या क्या हो सकता है, क्या क्या नहीं हो सकता, वो सब बताना पड़ता है. तो बिकॉज trauma is accident is a totally preventable cause, you know. जितना प्रिवेंशन करोगे जितना कम होगा। तो आप फास्ट चलाने से आपकी जिंदगी को क्यों खतरे में डाल रहे हो? ऐसा अवेयरनेस प्रोग्राम ऐसा हम रेगुलर यहाँ पे करते हैं राजकोट और जूनागढ़।
अगर आप जैसे आप करते हैं, मे बी वी कैन इन्वॉल्व इन दैट। हमारे पास कोर्सेस वगैरह भी हैं, भेज सकते हैं, एंड मे बी वी कैन हैव अ स्मॉल प्रेजेंटेशन देयर जस्ट टू मेक देयर अवेयरनेस। वो सब करते रहते हैं, एंड सर्टेनली वी वुड अप्रिशिएट दैट, वी वुड दैट। ठीक है, थैंक यू वेरी मच चिराग एंड डॉक्टर कांत।
On behalf of Cadila Pharmaceuticals, बहुत बहुत धन्यवाद। Thank you.
Thank you everyone. All the best.